Medicine has always been built around specialties. The right doctor for the right problem. Somewhere in that system, the pieces are supposed to come together into a complete picture of the patient. But anyone who has worked inside a health system knows that that picture rarely comes together the way it should. The handoffs are slow, the context gets lost, and the treatment a patient receives is shaped as much as by the structure of the system as by what's actually true about the specific anatomy, pathology, and biology, and by what they want when they come to see the physician. My guest today has rejected that reality, driven to unpack what precision medicine at scale can look like. In his early 20s, he was a fully trained general surgeon specializing in peripheral vascular surgery. But what he really wanted to do was operate on the brain, specifically revascularize it or open those blood vessels. To take everything he learned about vessels and apply it to the most complex and unforgiving organ in the human body. He came to the United States, walked into the lab of one of the world's foremost cerebrovascular and skull-based surgeons at the University of Washington, and started completely over. He then spent years at University of Buffalo along some of the biggest names in neurointerventional surgery, doing device development, laboratory research, and studying the biology of aneurysm growth with fluid dynamics of cerebrovascular disease and minimally invasive access to the deepest parts of the brain. He eventually became director of the cranial vascular, skull-based, and endovascular program at the University of Massachusetts, where he built a high-volume academic program and trained residents and fellows. And then he did something unusual. He left academic medicine to build his own brain, spine, and vascular neurosurgery institute in partnership with Sharp Healthcare in San Diego, where he organized his entire model around a single idea: put the patient in the center and bring every treatment to them. He is one of the very few neurosurgeons in the country who has experience performing complex open brain spine surgery, endovascular/catheter-based treatments, and computerized focused radiation treatments to the brain and spine. Just the right treatment for this patient decided by someone who can do all of that for them. That philosophy, individualized, precise, built around specific anatomy, pathology, and clinical picture of one person, is exactly what makes him such a compelling voice on where AI is taking medicine. He doesn't really see AI as a workflow tool. He sees it as the one true thing that makes precision medicine possible at scale: ability to synthesize imaging, anatomy, function, clinical context into a plan that's built into one patient, not a protocol designed for the average of all of them. He's been in the middle of that transformation for over a decade, watching AI move from the single data point into a connective tissue of an entire care system. Nobody in this conversation is better positioned to tell us what it actually feels like when all of that comes together at the bedside, and what it will take to get the rest of medicine there too. All right, welcome back, everybody. I'm so excited for today's guest, Dr. Natarajan. Thank you so much for joining me today. I wanted to start and just kind of get your background. And can you tell us a little bit more about how you started and where you are right now?
Thank you, Vivek. I'm Sabareesh Natarajan. I'm a neurosurgeon. I do neurointerventional surgery. I also do radiation treatments for the brain. I practice in San Diego, California currently. I started my career in India, went to medical school in India at a very young age, completed medical school, and trained actually as a general surgeon. Um, and one of my passions was actually doing blood vessel diseases, and I used to operate on the blood vessels of the body, not on the brain, but the rest of the body. Um, and I was intrigued to see whether I can do practice and transfer those skills to work on the brain. I was fortunate to get into the lab of one Dr. Shaker, who is one of the I was icons in microsurgery, cranial microsurgery, and I was fortunate to come and be with him at the University of Washington. He kind of taught me a lot about microanatomy of the brain, cerebral revascularization, principles of that. Um, and then I kind of wanted to train in neurosurgery because I didn't have any formal training, even though I could have understood. And I really wanted to see whether, he was an artist of a surgeon, and hey, can I do the surgery like that guy? That's really what intrigued me into getting into neurosurgery. But then, I quick realized that, the cerebrovascular disease is a specialty that is being siloed between a neurosurgeon and a neurointerventionist and a neurologist who treats stroke. And neurosurgeons have been predominantly treating, hemorrhagic disease and stayed out of the ischemic stroke realm. And why do we need to do that? Why are we siloed like that? Of course, it took a lot of years of training to be able to understand all of that. Same thing with neurocritical care. So I wanted to be someone who can provide neurosurgery, a little bit of neurology, neurocritical care, neurointervention, some radiation treatment, so that when I talk to my patient, I put the patient at the center, and I'm not biased by what I know to do or what I have knowledge of. So that's how I kind of trained through to kind of get each one of these through. I worked with Buffalo, New York, which I would say is the mecca of neurointervention in this country, with Nick Hopkins, Elad Levy, Adnan Siddiqui, and all these people. I stood on these shoulders and learned from them to learn their craft. And I did a lot of basic science research about aneurysm growth, development, fluid dynamics, understanding device development, and all of that. And then from there, went to Boston, where I started as just a neurosurgeon there. And then I quick became the director of their vascular program, skull base program, endovascular program. We had neurosurgery residency, we had neurosurgery fellowship, and I built a very robust practice there. Did a lot of neurosurgery, neurointervention, complex cases, to an extent that it gave me satiety, being there for 5 years, doing all these complex operations by yourself. Hey, I can do this, and I've done neurosurgery all different ways. And I learned through that process. Of course, I was not where I was had to be to do those when I started, but then in 5 years I matured. I knew what to do, what not to do, and that was a great, great maturing experience for me through that. And then I kind of was very interested in the business world, how practices work, how finances operate in our neuroscience core and system. And I was looking really to see whether, yeah, and this really comes, I think, from where I grew up and how, we used to own patients, meaning which we were taking care of people. We were not neurosurgeons. My dad is a surgeon, but he used to take care of a patient, not be a surgeon to them. And the other thing is my grandfather owned a hospital. My dad owns a hospital in India. So why not own your business of healthcare that you do? Why do you go and work in a hospital? It's interesting, this conversation, I think it was in the back of my mind. It really started as a conversation with my daughter. One day she's like, Dad, I don't understand why you go and work for a hospital, because you say this is not okay, that's not okay. Why don't you just do your own thing? Right? And she was, this is around 5 years ago, and this young girl was, 10 years old, and she told me this, and she said, I have a name for your practice, right? You operate on the brain, you operate on the spine, you operate on blood vessels, so we're going to call it BSV, brain spine vascular, and that is the name of my practice today. Right. So, and I think I was fortunate to find a partnership with Sharp Healthcare in San Diego, where we could set up our own practice and kind of a dream to reality, right? Where we can develop a business, have a good partnership where we can do what we wanted to do.
That's amazing. Wow. Okay. So lots of experience coming all the way from a different country, training somewhere else, coming here, getting established in academic environments, and then starting your own healthcare business, which is incredible story. I think that's been, commoditization and corporatization of medicine has been huge. Do you see this trend of, physicians owning their own business as being like a viable option in the future?
I, I, I personally, I'm biased. I really think that's the way it should be. And it's tough. I think neurosurgery facilitates it better because, it's a bigger cost center in general. But I think if physicians come together in other specialties, they can generate a bigger cost center. Again, you have to think about the things that we're not educated in medical school, which is finances, how to run your business lean, what you can do and cannot do depending on the pulse of your financial sheets, right? So that's something we are not schooled as physicians in our medical school or training, but that's something I think we all need to learn. Do you need an MBA to know that? No. Do you do mistakes when you start there? Yes, you do. But you learn from your mistakes and you try not to make big mistakes.
Right. So a lot of self-directed learning.
Correct.
Yeah. And I think that's tough for a lot of clinicians to do because, they're trying to step out of clinical medicine when, as your day starts really early in the morning, you're writing your notes until the evening, and then, okay, now I got to work on my business afterwards. I think a lot of people get held up on that fact. So it's really impressive as someone who's gone through, been a practicing neurosurgeon for 10 years, you've been able to establish this given how busy you guys normally are.
The other thing is, I think it's important to find the right people,
Yeah.
right? I need to understand that I'm good at doing neurosurgery. I'm good at taking care of people. That's where I'm going to spend 80% of my time, right? But I need to be a business owner, so I need to do that part too. But I don't want to do all of it. I need to find the right people, and I need to listen to them. I need to learn from them, and I need them to be part of the business. Being a CEO of a business is a little bit of, hey, stay out and see how everyone works for you, right? If you don't want to be the person working every day for it.
Yeah. Yeah, I got to delegate a little bit for sure. So, you talked a little bit about how, there are all these silos, and that's totally true. For the audience out there, when we're talking about neurosurgery and neurointerventional, neurointerventional, a lot of times they're doing like catheter-based therapies where they're using a small wire and guiding it through the vessels and using imaging to kind of trace that wire and perform interventions just with the catheter. So it's minimally invasive, little small incision, and they're guiding the wire up there. Whereas neurosurgery is, of course, going to be more open surgery. And there's different training pathways to neurointerventional. You can do it through radiology, you can do it through neurology now, and neurosurgery. But I think the bigger trend that we've been seeing is that neurosurgery has taken over the vast majority of, open work, of course, and then now a lot of endovascular work as well. But you talked a little bit about how these roles are siloed, but in the end, when you're caring for the patient and you're managing an acute stroke, there's so many people involved. There's neuroradiologists, looking at the scan. There's, the neurologist who's going to be admitting the patient, and the neurosurgeon and neurointerventionalists that are waiting to kind of see what the outputs are, or what the results are to find out what they need to do next. So we have this big shift in healthcare now where we have these new AI tools. So can we talk about like how you've seen AI help integrate some of that stuff where it used to be so siloed off?
you know, um, if you take 10 years ago, a patient needs to come to the ED, they have a stroke or intracerebral hemorrhage, the ED doc, sees the patient, a scan is done, there's a report that's generated by radiology, the ED doc in amongst like 20 patients they're taking care of at that point needs to identify that there's a patient who is having a stroke or patient who's having an intracerebral hemorrhage. They need to call the neurosurgeon or the neurologist, and the neurologist and neurosurgeon is going to give a set of instructions. Some cases there are both the neurosurgeon and neurologist involved, and they're giving two different instructions,
Yeah.
right? And then oh, what do we need to do next? And now the ED doctor needs to come in, and the neurosurgeon is not talking to the neurologist. And here there's a patient who's having strokes, and we all know stroke is a place where time is brain. You need to act quick, and none of these conversations, they are all siloed. They're all happening over multiple phone calls. But what has changed is we have these platforms where all all these specialties, starting from the ED to the neurologist to the neurosurgeon, our rapid response team, our clinical nurses, our stroke team, everyone is on a single platform. Again, this is evolving. It's not in every hospital, but we are trying to push towards that. And what that generates is it bypasses these silos. It bypasses these time deficits that we are kind of, and it increases conversation between all these people taking care of the people. Uh, the it's a good and a bad. The good things are, there's a history of what conversations went through. Someone who joins the conversation can say, "Hey, this is what happened," and they can kick off rather than, "Hey, what happened? Can you just update me?" That doesn't happen, and there's very good communication between people. But then, who's the owner of this decision,
Yeah.
right? Suppose there are three different inputs coming in the chat of, "Hey, what needs to be done?" Then who makes the decision of what needs to be done? And those are the things, the goods and the bads of AI. But I think in general, it has increased communication. it has increased workflow, and it has increased integration of teams in the hospital system, especially when a patient needs timely care. And I think we are doing way better than where we were in stroke care, especially, the time to seeing a patient, identifying a hemorrhage or a stroke, the time to having an intervention. All that has improved nationally in a lot of our comprehensive stroke centers since we have had the AI platforms.
Wow. And we've talked about this a little bit on the show in past episodes, but the other thing that I think other surgeons have brought up is like transfer issues. If you're getting an outside hospital transfer for potential stroke, having these perfusion softwares that are looking for mismatch, you can rule out some things that are like, oh, this person's just, hypoglycemic or something like that. Like false alerts go down too.
It's important to think about it as a system workflow. A lot of the time, again, it comes to ownership. A lot. What you're talking about is there's a hub hospital which does complex work, and then there are spoke hospitals where there's still care being provided, but not to the extent in the hub. And patients are being transferred from the spoke hospital into the hub hospital. Um, it's a different thing for stroke care versus, say, neurosurgical care in general. If you think about, let's say I have an intracerebral hemorrhage come in, it's a small intracerebral hemorrhage. I tell them, hey, you don't need to bring this patient into our hospital. The patient is stable. You keep it at the hub, at the spoke. What happens is, like 6 hours after, this patient has a bigger hemorrhage, right? So now, if you are not on it and you're not having ownership on it, and there's not a AI platform on it, you're going to miss this. The person who is there doesn't have the kind of acuity that you have or the knowledge that you have to take care of these patients. And they're going to have a big bleed. Patient is going to have a blown pupil, and you wouldn't know that. No one will know that. But what these platforms can do is, if you install it all through your spokes and hubs, there's an alert that comes into the people at the main hub that, what, in your spoke you said you're okay with having them there, but now that patient is having a problem, right? So now you can make the call. And I think that's what I call, it's not about, hey, the spoke owns the patient. You still own the patient because you consulted the patient, you own the patient. And when the patient has a problem, you can bring it into your hub.
Yeah. Yeah, makes sense. So a lot of improvement in both communication among clinicians and then also within the hospital system itself, getting people into the right bucket almost. Yeah. Okay, makes sense. And so we had talked a little bit earlier about just like where AI is now in terms of radiology. And we've talked about that in a lot of different episodes, but I'm super interested in your perspective as someone who's practicing in the OR every single day. What kind of new tools and what shifts are you seeing with the implementation of AI on the clinical side?
Radiology and AI have been in it for a long time. And I think a lot of AI tools we have today are geared towards what radiology really needed, which was, pattern recognition, identifying pathology versus no pathology, normal reads. That's really where it was geared to. But I think those are all superficial early generation AI. I think where AI needs to go to is deep learning and more precision medicine, where this is not about pattern recognition. This is about what I would do for this one patient, which is here right for me. And I think with that, we need a lot of data. We need a lot of system integration. In fact, data needs to come from probably centers all around the country, internationally, multiple countries actually, and all this data need to be pulled in. And what happens if there's a patient or a patient scenario? And when I say patient scenario, it's anatomy, it's pathology, it's clinical picture, right? And the expertise available around you, right? All of these things factor into what you can do for that patient. And what deep clinical AI learning can do is it matches all of these things and find that, what, there's a twin of this situation that happened in this country, in this time, in this hospital, and this was the procedural solution that worked. This is another twin in which we did this and it didn't work. And AI is going to learn over time what is the best solution for that particular problem, for that particular patient, with this group of anatomy, pathology, expertise, and clinical picture.
Right. Radiologists spend years training to interpret complex imaging and drive critical decisions. So, why are they spending their day chasing priors and manually populating reports? Rapid AI changes that. Automated workflows, deep clinical context at your fingertips, and seamless connection across the care team, all within the systems you already use, powered by an edge cloud platform built for reliability and enterprise scale. Navigator Pro puts radiology back where it belongs, at the center of patient care. Learn more at rapidai.com. So that would be almost like it's pulling treatment options from somewhere else.
Correct. Correct. And that is I think phase one,
Yeah.
right? And I think phase two gets needs to go into procedural solutions, right? And workflow integration. So okay, now you have a solution. Now, how is a hospital system going to integrate and get this care delivery through from AI? So they all need to be on an AI platform where they can say every team member can know this is what is probably the best procedural solution, or this is probably the best intervention, medical intervention, or surgical intervention, or procedural solution. And then how does that get into AI helping us for the procedural solution? AI, you already analyze your anatomy, and a lot of procedures are anatomy driven. And today, a lot of procedures we are getting into navigation, robotics. Um, so, can AI driven anatomical solutions be integrated into navigation and robotics and imaging to guide image guided procedures and navigation guided, robotic guided procedures? I think that is going to be the next level of AI integration, where AI is going to come into our procedural solutions. It's also getting into critical care, medical management, where, today we think about what's happening. A patient comes in, you say, hey, you have to keep the blood pressure between 130 to 150. And the patient is on just not the blood pressure medication, patients on sedation, patients on multiple other medications, which can alter your blood pressure. I really think, a nurse at the bedside trying to do this, or a clinician at the bedside doing this, is not precise. What really needs to happen is AI is able to say, you know what, this patient is on all these medications, and I need to keep the blood pressure between 130 to 150, and it's going to manipulate your infusions to keep your sedation score and your blood pressure goal at where it needs to be, right? So AI is going to come very deep into not just detecting problems. I think that's what radiology was about. Hey, this is normal, this is abnormal. That's what it was. But here, what we are trying to do is how to manage patients, how to do clinical solutions, how to do medical solutions, procedural solutions, and guide automation, robotics, and navigation. That's where AI is going to be.
Wow, that's really exciting. Have you seen any, as someone who works in the critical care sphere, have you seen any things that have come out that are like predictive of oncoming issues for a patient?
There's a lot of work going on. I think it's so ICP monitoring. We have smart ICP monitors today, where if you think about it, we used to monitor ICP, which is intracranial pressure, where we used to have a drain and you level it, and then it is measuring where your pressure is. If your level is at a higher level or lower level, then you got to re-zero it, right? That's archaic in my mind, right? In today's day and age, you should be able to measure pressure, what direction the patient is. So things like that are happening, where you're able to monitor better with technology we have. And again, that's the first level we are at. And a lot of this is regulated by FDA and stuff like that. I think we need to have a huge amount of data set to kind of prove that this is safe, and this works. So I really think it's going to happen, very sooner than what we think it is going to be there at.
Yeah, no, it's really exciting because it's almost like, you think back to how medicine was practiced like 100 years ago, and you're like, oh my gosh, I can't believe they did that, like leeching and like, treating, cocaine addiction with like heroin and stuff like that. You're like, what are we doing here? And I think it's going to be the same. Like some of these tools that we use right now to get this information, we're going to be like, wow, this is so outdated and archaic, and I can't believe we were operating on it. It's like almost when you're trying to, like treat a patient's like hemoglobin or something like that. You're trying to catch like transfusions. You're always behind on the labs, right? So you're never actually in that therapeutic window. Or actually, now I think about it, it's like PT-INR. Haven't done clinical medicine in a long time, but you have all these graphs and you're looking at these titrations and you're constantly. I just remember being like, this is never going to be therapeutic. I'm always 2 hours behind. The lab
Behind.
comes back and then I change the order, and then the lab comes back and I'm wrong again. So it's like those little things. I think we're going to be able to keep people in the appropriate range that they're supposed to be.
Critical care is going to change with AI, and AI is probably going to make minute to minute changes in what happens in a critical care unit. It's going to be, I think, as a derivation of critical care is anesthesia, if you think about it. In the operating room, anesthesiologist is the critical care person. They're manipulating critical care on a patient as I'm doing a procedural solution. That also is probably going to be AI driven. Minute to minute management of a patient in anesthesia is going to be AI driven. A lot of public thinks about brain tumors as a brain tumor. And even inside brain tumors, hey, you have a glial tumor, you have a glioblastoma. But today, brain tumor care is getting into genetics, into clinical picture plus genetics, and what does that mean? If you think about it, we all say, "Hey, glioblastoma is prognosis is very poor. This is what it is." But what we have found out is inside the glioblastoma, you have so many different genes that decide what the prognosis for this patient is. And each combination of these genes needs probably a different treatment, a different kind of surgery, which includes surgery. So I do surgery, radiation treatments to the brain. So how do we combine this, and how do we do the best for the patient? So I think AI is going to be able to have radiological and genomic correlation. So what's going to happen is, as AI learns, say, this was the genomic profile and this was the imaging. I really think, radiomics, as I call it, where, you're going to get an MRI. First, it's going to say, hey, this is a glioblastoma multiforme. And it's going to be able to say that this is the gene combination that I have seen with this imaging, so that you know the genetic profile of the tumor even before you do the histology, right? And that's going to direct care and treatment decisions for these patients. Uh, and once we have the imaging, I really think now we can go into intraoperative solutions where we use navigation, where you can create no-fly zones, right? I'm operating on the microscope. Today we have virtual reality. We know where I am looking in 3 dimension into someone's brain with a microscope. So you can probably prefabricate your surgery and say, hey, this is what I'm going to do. This is what I'm going to take out. This is where speech centers are. This is where visual centers are. This is where the tracts of the brain are in relation to the pathology I'm handling. So how do I navigate through these corridors to get into deep parts of the brain to take this pathology? How do I have, this is where I'm going to operate. So where are the no-fly zones? And you have to think about it as a procedure solution. We are not operating on a fixed environment. Our environment is changing. So as I take the tumor out, the brain is shifting. And there's going to be intraoperative ultrasound-based correction of the navigation where, ultrasound is going to keep looking at your brain. You're shifting. Now your navigation is off because what you thought where it is not anymore because now you removed tumor. So ultrasound is going to be automatically re-register your navigation and tell you where your tracks are, where your functional are. It's going to make surgery much more safer, much more automated and precise so the surgeon can concentrate on what they are doing and do not make errors as they're doing their surgery. I also really think there's going to be intraoperative histopathology where you will be able to shine your microscope on a tumor, and it should be able to tell you, hey, this is a GBM you're operating on, this is a meningioma you're operating on, or this is the part of the tumor that is higher grade, this is the part of the tumor that is lower grade. You know what? You've been operating on this, but now you're not on tumor, you're in brain. By just looking at the surface, it'll be able to tell you because that's I think, especially when you do intraaxial glial tumors, a lot of it comes from the surgeon's intuition because as we are operating, the tumor and the brain look very similar. But as you get experience, you know what is tumor, you know what is brain. Again, I think that is glorifying a surgeon. I think AI can do a better job as it learns, because machine learning and I think objectivity creates a lot more precision rather than a human saying, "Oh, I know what I'm doing."
Right. Right. Wow. So it sounds like almost I mean, it's kind of envisioning like a little like it's almost like a circle is drawn around the tumor where exactly you want to cut, and everything else is like don't cut here, don't cut there, and you're gonna have like this whole, basically a setup to kind of get
Yeah.
your margins and have clean
Correct. And
margins.
I've been doing this for 20 years. All of these principles applied even 20 years ago. It's just that I had to recreate that all in my brain, and I had to be the robot and the processor every day doing my surgery. But increasingly, what's happening is I'm able to create these procedural solutions on a computer. I'm able to see where the tumor is, where eloquent areas are, where fiber tracts of the brain are, and I'm able to plan and navigate my surgery. And intraoperative navigation and registration is getting better and better with ultrasound, and we are able to do a better job.
So we talked a little bit about the navigational, kind of the identification of all these pathologies. Can you tell me more about where we're moving in terms of robotics?
Robotics has three things in it: automation, haptic feedback, where without touching something, you know what's happening on the other end. And the other thing is teleoperation, where you can do a surgery from remote. Um, AI is going to really enable this and put these three things on steroids,
Yeah.
right? Because AI is going to think about what navigation, where the robot needs to go, what the robot needs to do, and it's going to give us immediate feedback on what is happening as the robot is working.
Right.
So AI is going to enable robotics, and it's going to enable us to do better solutions from remote. It's going to balance out and give healthcare equity around the community.
Yeah. Makes sense. So we've talked a lot about kind of the detection aspect of things and now kind of the navigational, almost pre-planning stuff. Talk to me more about the upcoming robotic interventions or what's coming down the field for us.
I've been interested in robotics for many, many years. Actually, at the University of Washington, almost 20 years ago, we did robotic experiments in neurosurgery. In my mind, robotics, the basic of robotics is automation, uh, teleoperation, and haptic feedback. A lot of solutions we have in neuroscience in general. I call it neuroscience because I don't know whether I'm a neurosurgeon,
Yeah,
neurointerventionalist,
it's the broad
neurologist.
term.
I'm
There
the
you go.
broad term,
Yeah.
right? Neuroscience in general is that they are really trajectory guides, where a robot goes and fits in a separate trajectory and says, "This is the direction you need to go." That, in my mind, is actually advanced navigation. It's really not robotics, right? So we need to get into this realm of real neurosurgical robotics. And I really think procedure, now that we have imaging, we talked about navigation, we talked about pre-planning based on AI. I think AI is going to direct robotics, because what it's going to do is, now your robotics is going to say, "I know this is safe, this is not safe." If you think about, we do skull-based tumors, where we have to go through all of this bone around the ear. We have to save the hearing apparatus. We have to save all the critical structures, and we have to drill the bone. It takes me 4 or 5 hours sometimes to drill the bone, and then I have to work on a tumor for another 5 or 6 hours, right? So if I can say a robot to say, "Hey, these are the safe zones. You should not go in here. I want all of this bone off." I think the robot can do a very good job in trying to at least drill 90% of it out for me, so that I can finish off the last 10% if needed to be safer. If you don't trust the robot, I really think the robot can take it to 100% at some point.
Right.
And then, that takes a lot of, cognitive load, a lot of time off my plate, so that I can focus when I'm working on the tumor around cranial nerves, around the brainstem. I can focus on that. So I think that is going to increasing, and robotic microsurgery is going to come through a lot. That is also going to enhance care delivery to remote areas around the world,
Yeah.
right? So today, if you think about it, we talked about dual trained neurosurgeons, which is neurosurgeons who do both neurosurgery and endovascular catheter-based work. I think I do both radiation too. I'm like a triple trained neurosurgeon. So that kind of expertise is very rare. If you take in the San Diego Metro, four of us do both. And now, when you go into rural areas, when you go outside this country, there's so many people who don't have that level of care. So I really think, robotics and teleoperation is going to change that, where your expertise, the care level is going to be the same no matter where you live in this world, no matter where you are in which corner of the world it is. And of course, it may be that, hey, someone who has the knowledge guides the other person who is taking care of the patient for a little bit, just to get them through that part, and then they take care of the patient. So it's going to really improve healthcare delivery, and it's going to make it more equal.
Yeah. When do we get to the point where you're doing surgery from California on somebody in a different country?
It's happening already. In fact, Vitor, who is in Toronto, just performed the first remote thrombectomy. Okay, where you can do thrombectomy from one country to the other country. It's interesting you asked the question. Like in 20 years ago at the University of Washington, we operated a drill in a desert in Egypt from the University of Washington. And this was part of a DARPA grant where, we wanted to put boreholes in soldiers to bring them out in the field, right? And with just a handheld this thing, you can do that. And now you're 20 years off, right? We should be able to do better than that,
Yeah,
right?
yeah, you would think so. Yeah.
Right. So I really think it's going to happen. We're going to be doing a lot of telesurgeries. Of course, there's going to be issues. Who gets licensed where? We are so again, the silos need to be broken, right? If care needs to be delivered, the silos need to be broken. And hey, what if there's someone in rural Nebraska who needs care, and there's someone in the state of California with a California license, and he's the guy to take care of it. How do we bridge this barrier?
That's huge. I mean, yeah, and I asked the same question. It's like how quickly until we progress. I did see something also recently about like someone doing an ophthalmological surgery as well, like an eye surgery, remotely as well. So I think these things are kind of coming down the pipeline, but maybe not there yet.
Yeah, I think it's regulated, but who 10 years ago thought that your car is going to drive by yourself, right? Um, you know, I, I was just telling him that 90% of the time I don't drive my car. It's coming. Is there going to be human intervention needed with robotics and AI and navigation? Yes, absolutely. At the end of the day, you still stay to be the mastermind of what happens, and the human touch of taking care of a person is there from you. But all this frees up your ability to do more. It frees up your cognitive load. It increases what you can do to your community and your people.
Yeah, awesome. So we talked a lot about actually caring for the patient themselves. Now you have a different lens here as someone who owns a business and is working kind of on a macro scale with multiple healthcare systems, hospitals, and things like that. Where do you see AI factoring into that stuff?
Um, AI is so we got to think about how we deliver care today. If you think about it, there's a lot of people who go to primary care, and then there are specialists, and there are emergent problems, and there are non-emergent problems, right? And for the emergent problems, patients find care in their community. But for urgent problems, they all come into acute care hospitals. Um, and what has happened is acute care hospitals are where the highest specialized people practice because they're dealing with more complicated problems and issues. How do we break this hierarchical system in healthcare? Right? I think AI is going to help with that, where the same care will be delivered, the same radiology care will be delivered, same procedural care will be delivered to the community, which is in the Apex Hospital. Because AI is going to integrate all of this through single platforms. It's going to find the pathology that needs to go up the ladder. It's also going to say, hey, you know what? This is too much to get into high acuity care. Come down. But with ownership and expertise still being there as an overlay over all of this.
Right. Every study tells a story, but getting to the right answer quickly can change everything. The challenge, everything is stat. Subtle findings demand intense focus, and critical patient context is often scattered or missing. Navigator Pro from Rapid AI addresses all three. intelligently prioritizing your work list, surfacing AI driven insights to reduce cognitive burden, and pulling deep clinical context automatically into the reading workflow. Plus, automated reporting that eliminates the manual drain. One workspace built for radiology. Learn more at rapidai.com. That makes sense. And I think we're seeing that a little bit in radiology already, where now with the number of remote radiologists and the amount of teleradiology that's going on, these areas that maybe didn't have access to a neuroradiologist or a body radiologist to look at a complex liver tumor, patients would have to drive from a rural part of whatever state they're in to the big academic center nearby to get their imaging even done, because it's got to get read by the specialists because the community radiologists are more generally trained. Now I think you're seeing this kind of democratization of imaging where every group has, different specialists. They might be living, in California and reading for a state on the East Coast. But the point is that your imaging may be read by someone who's really a specialist, and then that advances care. So then even if you got scanned in this outpatient center and 5 minutes away from your house, okay, now we have the report. We have enough here that says, okay, you need to get treated at a higher level center, and maybe even enough to say, hey, you need to go to this specific center because they do this kind of stuff.
It also, if you really think about it, patients are getting smarter. A lot of patients are using ChatGPT today,
Yeah.
right? Like I have friends who would say, you know what, I had this constellation of symptoms. I put it in ChatGPT. It told me exactly what's happening to me, right? And it told me where to go, what imaging I need, right? So, so I really think that there's something to think about that as physicians and healthcare providers, right? I think AI can actually diagnose a patient. It can do what a physician can do, where, this is what's happening to you. This is your symptoms. This is your signs, and this is your diagnosis. I really think AI can do that. And AI can tell you what imaging needed, right? Do we all need to be afraid that we are not going to have jobs? Absolutely not, right? It actually is going to make it easier. Like I was talking to you earlier that about, how I use AI to write my clinical notes, right? Initially, when I started using it, it's like I was like, I don't know whether this is going to do my job. Is it going to be personalized? Is it going to be is it going to be a template? All of that, right? But today, it is actually personalized. It actually it frees me of the anxiety that I need to remember all these things and write it as a note. Because when I go into a room, I can concentrate of taking care of the human in front of me. Right? It is not missing any single detail of our conversation in my note, and that makes it very personalized of that encounter that I had with my patient, and it documents everything. Normally, I would go and write a note in my office after that for 20 minutes, thinking about and remembering, making sure I have all the data in my note. Today, it takes me 2 minutes. And the more and more I use it, it's actually becoming 30 seconds. It's becoming 20 seconds because I know it's doing a good job. And I still need to oversee it because I think that's going to be there forever. And that's how I think procedure solutions, clinical medicine is going to be in the future.
I think there's a lot of parallels to radiology in that the same way. I think we're always trying to reduce cognitive burden, and if the AI can go through and measure all the things for you and find the tiny little nodule and flag it for you that you just kind of have to quickly review, that greatly reduces your cognitive burden throughout the workday. Your report is almost like auto generated, and you're actually like doing in-depth clinical chart review and giving a more nuanced answer and not worrying about the fine details. I think it's very similar to when you go see a patient in the clinic and you're trying to worry about all these details.
The bigger thing is a lot of people don't understand what a physician's cognitive load is. Like, you know, on an average day, I have 30 patients in hospitals who are sick who I'm taking care of. I perform probably two or three surgeries. I see 15 patients in my outpatient clinic. I'm on call. My PAs and APPs and residents are calling me with problems. There are people calling me. You know what? Last year you saw this patient. Now the patient needs a cardiology problem. Do you think I can do this? Right? All of this information is coming to me together, and I have to sort through this, and I cannot be not perfect, right? As a neurosurgeon, the biggest thing is you cannot be not perfect because you'll hurt people if you're not perfect. And the cognitive load coming into you every day is so much, and we as physicians need to think about how we can preserve ourselves. And AI is going to help us preserve ourselves rather than take our jobs, because it's going to let us do what we can do better. It's going to increase the longevity of physicians, actually, because you don't need to do a lot of these mundane tasks, and you need to rely on, hey, something is summarizing this way, something is getting me a little further than where I need to start to do my job.
Right. Right. That makes sense. So tell me a little bit more about spinal care, because it's not just the brain that you guys are treating. What advances are we seeing in AI with spinal care?
Spinal disease is very common. It's almost like stroke neurology, right? There's so many patients who have back pain, leg pain, cervical pain, and there is conservative management where they go into chiropractors, physical therapists, injection, surgical solutions, minimal invasive stuff, and then people who really need surgery. Today, what's happening is people, I have some of my partners who specialize just in spinal disease. They have to see 40 patients in the clinic, and then they have one patient to operate on, right? At the end of the day, it's taxing and tiring. I think as we talked initially about the cognitive load of physicians, and that's where I think AI can do a better job. I think AI can um, uh, look at their symptoms, look at their signs. It can look at their radiology, interpret the clinical and radiological information, and say, you know what, you don't need to go and see a spinal surgeon. You need to go and get your medication, you need to get physical therapy, you need to have all these things, and detect red flag symptoms where, hey, these are the red flag symptoms, now you need to go to a spinal surgeon. So I really think it decreases the cognitive load and the burden on a spinal surgeon today, and just taking care of spinal disease and integrating care of all these people who do conservative management, starting from a pain specialist to a physical therapist to a spinal surgeon. And I think that's going to change spinal care with AI. And then when it comes to procedural solutions, I think robotics and if you think about wherever when you work on bone, there's a lot of robotic. There's robotic hip replacements, there's robotic knee replacements, but spinal disease and robotics haven't gotten there yet. We use the same thing, which is a trajectory guide, which we call as robotics. But what we really need to go is, hey, you're able to drill the bone automated, and you can do no-fly zones. AI can say in this specific anatomy, right? Because every person's anatomy is different. You can't just say, hey, I'm going to drill this off. So based on navigation and intraoperative imaging of the bone and soft tissue, you'll be able to say, okay, this part of the anatomy needs to be removed by a robotic tool, and AI can guide doing that. And that kind of facilitates you working on neural structures after that. And the other big thing we do in spinal disease is we correct alignments. If you think about it, your head needs to be on your shoulder needs to be on your sacrum needs to be on your knee, and knee needs to be on your feet, right? And that's how we as human beings stand tall. And patients with spinal disease, this gets altered, and that's what we call as a deformity. And a lot of spinal disease, when you correct your spinal disease, previously people never used to pay attention to this alignment issue. I think with AI and our ability to capture general alignment of the spine, I think every single maneuver you do, AI is going to tell you, if you do this, your alignment is going to be this different, and the patient may or may not be in a good position after you correct the alignment. And there are surgeries where we go in to correct the alignment, and it's going to tell you, if you do, okay, you're going to put in this interbody, you're going to put in these pedicle screws, you're going to do these osteotomies. A combination of this with the patient's stiffness of the spine, with the patient's, how stiff or how ankylosed this patient is going to give us an ability to do what we can do precisely and get the best results for a patient.
Wow, that sounds amazing. So basically, it's going to give you real time feedback on, hey, if you do this, this is where you're going to land. So then you can kind of make micro adjustments during your operation to ensure you get the best outcome.
And again, this comes from deep machine learning and data coming from, I would say, thousands of hospitals across countries, so that it finds the trend, right? It finds the trend as we started saying, hey, hey, this patient, we did this manipulation with this amount of spine flexibility, with this characteristics, and this didn't work, and this worked.
Yeah. Dr. Natarajan, this has been fantastic. It is so great to hear kind of the clinical perspective on things. You're the first guest we've had that's actually, actively working on multiple fronts in healthcare like this. So it's been great to hear your perspective. I really appreciate it.
Thank you. It was a pleasure.